Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiging, telos ng sinakalan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyang ka ng magiting, sa mandulupin, di ka pasisitin, sa nagagang tutok sa simoy at sa langit mo pagaw, ay hinatang tulad, awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan pa may di magtitindig. Luman ang araw ng walhaging pagsinta, buhay langit sa piling ko. Ang inigaya na pagkay mga amin, ang mamatay ng dahil sa'yo.
Kaagapay sa ating laban, kanser ng kabataan. Mahirap man o mayaman, karamdamay iibsan. Gamit siyensya at pananalig, subukang mapawi ang ligalig. Lahat ng paraan iuusig na may malasakit at pag-ibig. Minsa'y magtatagumpay sa paglunas ng sakit. Madalas maiibsan, hirap at pait, kailangan lang mag-arog at magmalasakit. PSPO, inyong kasama, puno ng malasakit at pag-aaruga. PSPO, inyong kasama, kaakibat sa hirap at ginhawa. Mahirap man ang daang tatahakin, loob tibayan at palakasin. Ang labang to'y sa Diyos at di atin, maging tapat lang sa tungkulin. Minsa'y magtatagumpay sa paglunas ng sakit. Madalas maiibsan, hirap at pait, kailangan lang mag-arog at magmalasakit. PSPO, inyong kasama, puno ng malasakit at pag-aaruga. PSPO, inyong kaakibat sa hirap at ginhawa. Kaakibat sa hirap at ginhawa. Kaakibat sa hirap at ginhawa.
To give the opening remarks, may I call on the Mount Elizabeth Hospital Philippine Office Director, Mr. Edwin Salonga.
A pleasant and beautiful morning to everyone. Philippine Society of Pediatric Oncology, PSPO President Dr. Michelle Rodriguez, PSPO CME Committee Chair Dr. Domilin Coniconde Arca, PSPO Immediate Past President Dr. Patricia Alcasabas, our guest speaker from Singapore, Dr. Lee Kuo Ann, Mr. Vincent Lai, Philippine Country Manager from IHH Healthcare Singapore and our Philippine office team. Guests from Mount Elizabeth Hospital, Singapore, Philippine office, and the wonderful doctors who are here with us today. I take this opportunity to thank everyone here today for joining us at the Mount Elizabeth Hospital, Singapore, Philippine office, Cocktails and Conversation CME, in collaboration with the Philippine Society of Pediatric Oncology on the topic Proton Beam Therapy for Pediatric Medical and Radiation Oncologists. Many thanks to the Mount Elizabeth Hospital, Singapore, and our diligent and hardworking Philippine office team, Dory D. Jan and Cheradine, for making this continuing series of cocktails and conversation events, which we had commenced last year, possible. I'm Edwin Salonga, Director at Mount Elizabeth and Glen Eagles Hospital, Singapore, Philippine office. And I welcome everyone to this event. Mount Elizabeth Hospital, Singapore, Philippine office is about opening the door for new healthcare possibilities and synergistic collaboration with Philippine doctors, and to be able to utilize the advanced medical technologies that are already available at Mount Elizabeth Hospitals, Singapore. Our Philippine office is located at the ground floor of this building, Marco Polo Hotel in Ortigas Center. And our Philippine office team is committed to serve. We look forward to a great partnership with all of the doctors here today. So we look forward to having more CME events with the PSPO. Thank you very much.
Thank you so much, Sir Edwin. Our moderator for today is a pediatric hematology oncology consultant. She is the head of the section of Pediatric Hematology Oncology of the Department of Pediatrics Perpetual Health Medical Center, Las Piñas, and the current head of CME Committee of PSPO. To introduce our speaker, doctors, please help me welcome Dr. Domilin Coniconde Arca.
Good morning, everyone. Nice to see all of you here. So welcome again to the first CME activity of PSPO, of course, with the help of IAH Healthcare Singapore and Mount Elizabeth Novena Hospital. So to introduce our speaker, our expert speaker, Dr. Lee Kuo Ann, is a radiation oncologist who has more than 8 years of experience in the field. Currently, he's a senior consultant radiation oncologist at the Mount Elizabeth Novena Hospital in Singapore. He obtained his medical degree from the National University of Singapore and was awarded a Higher Manpower Development Program Fellowship to train in clinical oncology at the renowned Royal Marsden Hospital in London from 2001 to 2003. He subsequently became a fellow of the Royal College of Radiologists in UK for clinical oncology. He has worked as a consultant radiation oncologist at the National Cancer Center, Singapore, where he subspecialized in the treatment of gastrointestinal cancers and sarcomas. Dr. Lee is a member and is part of the executive committees in the College of Radiologists, Singapore Society of Oncology, and the Singapore Radiological Society. He has also taken on the role of educator and has taught at the Faculty of Medical Sciences at Nanyang Polytechnic. And he's involved with training visiting oncologists to the National Cancer Center in Singapore. He has published works both in local and international journals and has also presented at international conferences. So without further ado, ladies and gentlemen, dear doctors, let's welcome Dr. Lee Kuo Ann.
Hi, thank you for all coming today. I'm actually honored that you took your Saturday off to come and hear this, so I'm very honored. Thank you, Dr. Raka, for the kind introduction. Today I'm going to talk a bit about proton therapy. So I hear the healthcare here is actually really good. So it might be that for regular radiotherapy, you're already doing a very good job, and you might not need to send to Singapore very much. But proton therapy is new. It's quite expensive, big machine, so not so many countries have it. So we're glad that we'll be starting our proton service, and maybe someday we could be of assistance. In fact, I just heard yesterday that we might be starting our proton service in the next 2 weeks or so. And one of my patients might be the first to start the treatment. Are you all mostly medical oncologists here, or I mean pediatric oncologists or radiation oncologists? Any? Good. Okay, so this is the scope for our outline today. I'll introduce what is proton therapy, why it is useful in pediatric patients, take a look at some examples, maybe some of the technical issues and potential pitfalls, and also cover the sticky issue about costs. So what is proton therapy? First, you need to understand what is normal X-ray radiotherapy. So this is a typical, what we call a depth dose curve profile of X-ray therapy. Here you see as the radiation enters the body, it's the most strong. It's like a beam of light. At the start, it is the brightest. Then as you go in distance, the light gets dimmer and dimmer. So by the time the X-ray gets to the tumor, some number of centimeters inside the body, it has already lost a good amount of its energy to normal tissues on the way in. And then after it treats the tumor, it doesn't stop there. It exits the tumor and goes out on the other side of the body and also causes collateral injury on the way out. Contrast that to proton therapy. So this is the depth dose curve of a single proton particle. As it enters the body, it releases a low amount of energy. So it causes some but lower amount of damage. Then the phenomenon called a Bragg peak occurs at the end of the proton range, where it suddenly comes to an abrupt stop, releasing all of its energy in a very short distance. And you want that to happen within the tumor. Once it's released all its energy, nothing comes out on the other side. So you have reduced tissue injury on the way in and especially on the way out. So that results in less normal injury. So it's, in my mind, something like playing golf. So you need to shoot the particle in the correct direction at the right speed towards the target. And if you got those two correct, it will land there and nothing will come out on the other side. And how you make sure you get the right speed, you have to account for the distance and all the things in between the source and the tumor, such as how much fat, skin, bone, air, and so on. You take all that into account and then you shoot the proton at the correct speed. So this is the proton center that we have. Up on the left is the source of the protons and the accelerator called a cyclotron. And then the cyclotron will accelerate the protons through, there's an energy selection system, which will then get to the gantry. The gantry is used to turn the proton to whichever direction you want to enter the patient from. And then underneath that is the treatment room. So let's start at the proton source. To accelerate the proton, video is not working. Okay, that video didn't quite work. Actually, it's a slingshot. So you're supposed to sling to accelerate and then you release the stone. So that's somewhat what's happening inside the proton cyclotron. The protons are accelerated to 2/3 the speed of light, and then they come out on the other end where they are able to penetrate maybe about 15-25 centimeters range. Then when it gets to the patient, we use a technology called scanning beam, something like a 3D printer or old television scan. So this single narrow beam of protons will be controlled in the XY direction using magnets. And then you can scan it across the plane to paint the 3D shape of the plane, or first the initial 2D shape. Then you reduce the energy of the proton slightly so that it stops maybe 3 millimeters nearer, and then you paint another layer, and then you go layer by layer until you've completed the 3D shape. This is done in a fraction of a second, or within a few minutes if it is a more complex case. And then what you then get is on the top right, what we call a spread out back peak, where the dose profile, again, distal to the tumor, nothing, proximally maybe giving about 70% energy, which is still better than X-rays. So how does this compare to our current standard? Currently, we use X-rays, and the current best treatment might be what we call VMAT or IMRT. That way, we are able to control the high dose very well. The conformality of the high dose, which is the red area, for instance, you see in this case of prostate cancer, it bends around the rectum and we can spare the rectum. But the price to pay is that there's a lot of low dose everywhere. The blues and the greens colors that you see are the low doses. So compare that on the right to the proton beam. You still maintain the high dose conformality, the red color high dose, but you notice that the green and blues are much less because you don't need so many beam angles to have both conformality as well as low dose. So that may translate to certain expected benefits. And who are the patients that in general, maybe stepping back, not just for pediatrics, these are the kind of patients that may potentially benefit more from proton therapy than regular X-rays. And at the top of the list, I would like to point out young patients. Okay, so as a case example, I'm going to show you a case of cranial-spinal irradiation. This patient of mine going to complete his CSI today. He's unfortunately just going to miss his proton therapy license, our license, by about a week. But we planned for him anyway, actually. So he had a standard wrist medulloblastoma. And this is how we set him up as if for proton therapy. So we have a backlog bag for the body. For the head, we had a mold care, customized mold for the back to support the head and the skull. And then in front, also a regular face mask. And then we do 2 mm slice thickness scans without contrast, including all the supporting structures so that that can be taken into account in the calculation of the proton energy. Then I started contouring. We use the PSYOP guidelines. You can get this online. In the past, with 2D, it doesn't matter. You just shoot left and right. Everything is in. But if you are going to very conformal therapy, then you actually have to contour accurately your target, or else you will miss disease or include things that you don't otherwise need to include. So having contoured all his targets as well as the organs at risk. So this is a young man, by the way. He's about 23 years old. So he's completed his growth. And you notice that I did not include his entire vertebral body in the target. So that way we can actually further reduce the dose to the bone marrow and the anterior structures. And then when it comes to the physicist, he does his planning. We don't need a lot of fields. For the cranial part, there's 2 posterior oblique beams, and the spine is a single posterior beam. And of course, this is too long. He's a full adult patient. The field cannot cover all at once. So we need matching fields. So how do we match the fields at cranial to thorax, thorax to lumbar spinal, lumbar sacral? Is that at the junction, we will have about a 4 centimeter overlap area. And the junction, those, as you can see over here, the upper field will have a gradually decreasing dose gradient, and the lower one starts to have an increasing one, and they cross over and then they overlap to give you your dose homogeneity. And that's how we get the robustness for matching fields, so that if there's any inaccuracy in superior inferior matching, the effect would be very mild. In the normal 3D or 2D way, we have been using feathering technique. But this is how we do it with protons. And this was the dose distribution. This is the best case scenario for showing the benefit of protons in versus X-rays. Because it's a large field, we treat many normal organ structures, so the potential benefit is the greatest. Notice that all the anterior structures, oral cavity, thyroid, larynx, pharynx, heart, lungs, kidneys, pancreas, and the reproductive organs or ovaries and the if it was a female, would be saved by the proton therapy. And these are the axial slices. Again, within the head, notice how even the dose are compared to VMAT. The dose homogeneity of protons seems to be superior. We have lower doses. We are able to spare the eyes, the lens, and the lacrimal glands. And then coming to the oral part, less dose into the salivary glands and the oral cavity, and then much less dose into the heart and lungs. So potentially lesser future problems with heart and lung disease. And then down in the abdomen, lesser dose into the kidneys, liver, pancreas, bowels, and pelvic organs. And these are the dose table just to say what we just saw. So what's the potential benefit for young children? These are the indications for on X-rays, radiotherapy in children. So the two most common will be the CNS group and then the sarcoma group. So CNS will be your medulloblastomas, ependymoma, germ cell tumors, craniopharyngiomas, and gliomas. Base of skull tumors, of course, not terribly common, but this is another classic indication for protons. And then the sarcoma group, like the rhabdomyosarcomas, Ewing's. And then you have the rest, Wilms, neuroblastoma. So because of the side effects, the known side effects of radiotherapy on growth and second cancer risk and neurocognition and endocrine function, we try to avoid radiation whenever we can. And if we have to give it, we try to reduce the volume or the dose. But some trials have shown that we cannot avoid radiation, right? And so it's a necessary evil in order to achieve cure. But this price of side effect of survival is that the patients may then wind up with problems with schooling and education. And then in the future, after they've survived, are they able to find a job and work productively in society? Are they able to find a partner and get married? Does it affect their emotional health and depression? So if we can reduce the toxicity of radiation, then we will improve these outcomes. So I will just take a few of these examples. So second malignancy risk is one of the greatest fears that we have for radiation in children. Because they are young, their cells are immature, they are sensitive to radiation, and they haven't completed their growth yet. So their risk of malignancy is higher. But I just want to put this slide out to say that it cannot blame all on the radiation. Why they got cancer when they are young is they already have some intrinsic cancer risks, like for instance, retinoblastoma gene. And then chemotherapy also does have some risk of its own. So proton therapy compared to X-rays, a number of trials, retrospective have been done. And in this case, this example is often quoted trial where they did a match case analysis of X-rays versus protons and found that the proton therapy had a odds ratio, a reduction by about 2/3 in the risk of second malignancy in the future. And we of course don't treat retinoblastoma very often, but the gene confers a higher risk of second malignancies, especially sarcomas. We did have to radiate, then proton therapy compared to X-rays reduces the second malignancy risk. Second side effect, neurocognition. This is a randomized trial to prove that if you can have more conformal radiation, you reduce neurocognitive side effects. And this out of India, where they were not using protons in this case, but conventional radiotherapy versus IMRT or stereotactic radiotherapy. And they found that the cognitive preservation was better with conformal radiation techniques. So even more conformal than stereotactic radiotherapy would be proton therapy. So here's an example of a germ cell tumor dosimetric comparison. On the left, you have a picture of IMRT, on the right versus intensity modulated proton therapy. And notice that in the temporal lobes and the hippocampus, which are thought to be important for learning and memory and cognition, that the proton therapy has a much lower dose entering those areas. And in this trial that they found, you can see that there's a top right, there's a marked decrease in the radiation exposure to the temporal lobes. And on the lower left, the brain in general. Another trial showing, comparing again proton versus photons, they both have a negative effect. Any radiation will have an effect on IQ, but the decline in proton is less bad, minus 0.7 per year versus minus 1.1 for X-rays. Another study showing similar IQ 88 versus 96. Okay, third is on endocrine. So this is a study comparing proton versus photons. The incidence of hypothyroidism was lower for protons, 17% versus 49% for X-rays. And sex hormone deficiency was 0% for protons versus 17% for X-rays. They didn't find a difference in growth hormone. It is known that in the pituitary, the growth hormone is the first to be knocked out. So if you're doing craniospinal irradiation, typically the dose is going to be exceeding 18 gray, which is the dose at which we knock out growth hormone. So that remains a problem. But the more resistant cells for the TSH reduction and FSH-LH are more resistant. So we are able to spare that better with protons. Any level 1 strong evidence to prove that protons is better? Unfortunately, very little. To do a randomized trial is considered not very ethical. Not many doctors are willing to randomize a group to no proton. Can you say, can you in good faith tell you, I'm going to let the computer choose no protons for you? Not many doctors are willing to do that and probably never will. So we will not get level 1 evidence, but there are many retrospective and prospective comparisons. And just 2 slides. This is a slide of CNS trials all over. And this is a slide for the non-CNS outside the brain, again, all types. And in general, those show equivalent cancer control with lower side effect risk. Okay, I'm going to switch gears a bit to the issues with proton therapy, some things which may see more in proton than in X-rays. Okay, first issue is positional uncertainty. You need to shoot your proton at the right target or else you miss. And protons are very susceptible to changes more so than X-rays. So this can be patient position different, a bit too superior, inferior, lateral, or if you're treating in the pelvis, the bladder filling or rectal filling or gas in the bowel, that could change it. So if there's too much gas, you may not want to use protons. You may want X-rays to be a more reliable treatment. Is anything in the chest because of respiratory motion, the diaphragm moving, the heart moving, the proton may overshoot or undershoot. Then the second issue is what we call range uncertainty. Because not only you have to shoot in the correct direction, but also at the right speed. And any change in the patient may cause the proton to end too early or too late. For instance, patient weight gain or weight loss. they may have no appetite due to chemotherapy, or maybe the mucositis from the radiation, or nausea, may gain or lose weight. Second is skin folds. We have to be very careful when we set the patient up, the therapist, so that you don't introduce a skin fold where there was none, or else the proton will not stop or overshoot. And then tumor may respond. It started big, halfway through treatment, it's already shrunk halfway. The proton may overshoot now into, say, a spinal cord or brainstem. If you are having fields that treat the head coming through the sinus, halfway through you may have mucositis or filling up of the sinus with fluid. That may stop the proton short. And if you don't have the correct speed, this will happen. I thought it was quite funny. So we have mitigating measures. This is more of interest to the radiation oncologists among you. So for uncertainty in setup, we use software in the planning computer to introduce hypothetical variations. Patient maybe too front, too back, too up, too down. And then introduce into the optimization software, the proton speed to account for potential errors. So for instance, you may need to treat a little bit extra beyond and a little bit extra proximal, so that even if there's a setup error, the tumor is not undercovered. Then we need better immobilization, and every day we will have to do image guidance so that the patient's position is exactly set up right. And then we have to be careful with the number of beams. Fewer beams are good because you expose less normal tissue, but too few, and then you have a concentration of high dose coming through, one beam, for instance. And the second is that it's less robust. Any slight error in positional setup or weight gain, weight loss may cause an overdose or underdose. And secondly, there is this property called higher LET. I think I'll come back to that later. Yeah. So during treatment period, we will have a weekly CT scan, not just a daily one for setup, but we'll bring them to simulation to do a CT scan to calculate the dose on the current patient's weight and shape. And you can see any more extra dose in the OARs, or normal organs at risk, or underdose of the tumor due to the changes that we talked about. And if you see that, we will repeat the computer plan to adjust to the new body shape. Okay, this is what I was going to say just now. If you look at the depth dose curve of the so-called spread out Bragg peak for proton, at the end of the range of the proton, where it's starting to come to a complete stop, the biological effect of the proton actually increases above what we expected. And that can cause problems. If you have a proton beam that is ending just in front or inside, let's say the brainstem, that end of range increase in the biological effect of the proton would then cause brainstem injury. And there have been reports before of patients even passing away due to radionecrosis in the brainstem. So first, we have to be aware of the problem. Having been aware of the problem, there are measures that we can take to prevent this from occurring, using more beam angles, making sure that the high dose, high biological effect, end of range effect, the LET we call it, is not ending inside the brainstem, and using more than one beam. So if you do that, then actually you find that compared to X-rays versus the incidence of radionecrosis in the brainstem increased. Okay, I think one of the last few topics already, cost effectiveness. Protons have a high upfront cost. It's about 2 times the price of VMAT. The machine itself is 10 times the price of a regular radiotherapy machine. And so, of course, expectedly, the cost will cost more. But you also have to take in time to account the lifetime cost of the patient's life. So this will include the cost of treating hormone deficiencies such as growth hormones, more at the start and then a bit less once after puberty. Hearing aids, so for instance, ototoxicity, cardiac disease, some 10, 15 years down the road, they have a heart attack or angina, that costs money to treat. If they get a radiation-induced malignancy, not only that's affect quality of life, survival, but that also is a cost in itself. Early menopause, osteoporosis prevention and treatment, that costs money. If the patient's IQ was affected, cannot get a job, that's a very big economic loss. And then fertility, if they need to then have future fertility treatments. So study was done, this report in Netherlands, doing a cost-effective analysis, and they found that with proton therapy, despite the higher upfront cost, they actually have a net saving of 23,000 euro per patient. So patient selection, is every patient a good candidate for protons? If you look at the American guidelines, they just say pediatric, solid, and CNS tumors. The middle one is a paper from a consensus meeting of pediatric specialists and oncologists. And the red is photon, too small for you to see. Blue is proton. And you can see that for most tumors, blue is there. So they do agree that protons is recommended in many pediatric cancers. Those that is a bit less, you can see is Wilms tumor, because often that might be whole abdominal or whole flank radiation. Perhaps X-rays are going to do a good job, as good a job, maybe even better. If you send a patient to Singapore, the government has decided for me what I can treat and what I cannot treat. So this is the list, which is actually online from the Singapore Ministry of Health website. And on the left are the adult, any age indications. On the right are specific for children or young adults, anyone less than 25. So at the top, you see the CNS tumors, medulloblastoma, epidymoma, intracranial, and craniopharyngioma, and so on and so on. Head and neck cancers, such as retinoblastoma, chordoma, esthesioneuroblastoma, neuroblastoma, salivary gland, and then the sarcoma group, rhabdo, Ewing's, neuroblast, and then others in the rest of the body. So as I mentioned, there are some cases where maybe X-ray is just as good or better. Total body irradiation, nothing to gain because you're already treating everything. Whole abdominal for the same reason. Whole lung, same reason. If the patient is palliative, short life expectancy, might come to Singapore, better to spend your time back home in family, or might be metastatic shock prognosis and so on. So in summary, proton therapy, technologically speaking, has less normal tissue exposure, similar efficacy, may result therefore in less late toxicity and second malignancy risk. In the long run, it's cost effective and is recommended by most expert guidelines and panels. In my center, we have the IBA Proteus 1 machine. This is the latest generation proton machine. It uses pencil beam scanning as opposed to an older technology called passive scatter. Passive scatter had some disadvantages where there was more dose proximally, and also they had produced neutrons which exit beyond the tumor and may increase the future risk of radiation-induced malignancy. So pencil beam scatter is a newer technology of protons. And then older machines didn't have cone beam CTs built in. All the new ones do, ours included. We have a 6-dimensional, 6 degree of freedom couch. So we can set the patient correctly in all 6 degrees of freedom, up, down, left, right, pitch, roll, and yaw. Cost we've already considered. The indicative cost is about 60,000 Singapore dollars. which I'm told is about 2.5 million pesos. Having said that, this is actually sounds expensive, but if you compare to other proton centers around the world, it's competitive. We're certainly cheaper than America, a lot. We are cheaper than Japan, Korea, I believe so, not entirely sure. Actually comparable to India. And there are two other proton centers in Singapore. They haven't published their price yet, but indicatively, I hear they may even be more expensive than my center. So I think if you need to send somewhere, do consider us. Thank you very much.
Thank you, Dr. Lee. If I may invite you, please, in front. Sorry.
I understand.
Yeah.
Okay. So that's been clarified. Regarding my feedback, I think around 11 years ago, we had an opportunity to treat a child with unresectable Ewing sarcoma in the spine. So she presented with pain, persistent pain. Later, the muscles atrophied and ambulation was affected. There was late diagnosis because she was being treated as a rheumatologic condition. So by the time we received the patient, she didn't want to walk anymore. To cut the story short, of course, we had to give chemotherapy. It was unresectable, but biopsy was done. We gave gene therapy, P53 gene therapy. At that time, the brand name was Gendicin and Proton Beam. May I know when Proton Beam started in Singapore, Dr. Lee?
So there are 3 centers that are just about to open. None of them are open yet.
Okay.
So my center, I heard yesterday, in fact, the news just came that we might be starting in about a week and a half.
Okay.
I hope we are the first.
A week and a half.
Otherwise, we'll be all around the same time.
Okay,
so,
sir.
Yeah.
So that's the reason why we had to send the child to South Korea.
Yes.
It was the nearest at
Yes.
that time.
Yes.
So we didn't find one
Yeah.
in Singapore, not because we don't like, but
Yeah.
because at that time it wasn't available. The good news is she's alive. She's ambulatory. Muscles are good. She can run, dance, and ride a horse. By the way, the parents were British. She's back in the UK, and I'm still in touch with the family, or they actually keep in touch with me. So that's the good news.
Wow.
However, she underwent hip surgery.
Yes.
I don't have the details, doctor, but I was wondering, was it related to what we did to the child in the past? What are your thoughts about it? I don't think the hips were hit by the proton therapy. I just contacted the father now. I'm asking him why, but I don't have the reply yet. So that's my
maybe I guess
question, sir.
since it is out of the field and it says the cancer is not there, not a direct effect, then since it is a spine, I'm guessing, could it be that she has scoliosis or some other issue? She's not walking too straight, and she's putting more weight on one side than the other, perhaps leading to some degenerative disease on one side.
Okay,
I'm
I'll try to
guessing.
find out.
Yeah.
I will try to find out. The cost was the same, 3 million. That was 11 years ago.
Yeah.
Still the same, 3 million pesos. Thank you. Thank you, sir.
Thank you, Dr. Lee. Any more questions? Yes, sir. Reminder for our online participants, you may chat. You may type your questions in the chat box.
Thank you, Dr. Lee Kuo Ann, for that very informative lecture. So I'm Dr. Jason Ko. So I'm a radiation oncologist from the Philippine Children's Medical Center. So with regards to the use of proton in pediatric patients, in my experience before as my training, we don't have a proton machine in Canada. But what we do is that we do 2 plans. We do one X-ray and one protons. The planner there can do both. And then those patients who will benefit from proton, we refer to the US. So here, which sites do you think that will benefit most from using Proton, for example, for the pediatric patients in the Philippines to be treated in Protons? For, of course, there's a long list, but we are in a low to middle income country. So if you will be prioritizing those sites in which you think Proton has a great benefit, not just an incremental benefits from using Protons. Thank you.
Thanks. So we also do, we might do a comparison plan as well. So like the CSI, we did a comparison plan. I also just, I'm treating one patient now with VMAT for maxillary sinus, 18-year-old girl. And we did a comparison Proton with VMAT. There is a benefit in the Proton for reducing dose to the brainstem, spinal cord, which is almost zero. And the salivary glands, the ipsilateral side still affects a big tumor, but the contralateral side again almost zero. The contralateral eye almost zero. Ipsilateral eye, the dose was slightly higher. So mean dose lower, but the peak dose a bit higher because the tumor was touching the eye. That's where VMAT actually has a slight advantage. The dose fall off a bit sharper. So in terms of which patient groups may benefit the most, I think CSI #1, because very big fields, a lot of organs get exposed. I always feel uncomfortable having to do CSI, whether it's like germ cell tumor. Is there really metastases, the CSF? You know, try to convince myself that it isn't. Because, so whether it's a medulloblastoma or germ cell tumor, I think that would be a big advantage. Probably many brain tumors, like craniopharyngioma, there's lesser dose to the temporal lobes. So the CNS function, the cognition functioning may be better. Ependymoma has also been shown to be superior, lesser dose to the cochlea as well as the temporal lobes. Rhabdomyosarcoma, it's lesser general dose elsewhere, so that would be a good for second malignancy risk. Base of skull tumors, chondrosarcoma, they need high doses. Yeah, so that one also clearly, I think proton therapy is superior. Lymphomas, harder to say. And also in the chest, there are often moving targets. And the dose is not so high. So Wilms also less likely, the dose is quite low. 10 gray, so we're not so scared of the side effects. So I think, yeah, some tumors more than others.
Thank you.
Thanks.
Questions from the, yes, sir.
Morning, Doctor. Thank you for that comprehensive lecture. I'm Dr. John Mark Carabeo. I'm a oncologist here in the Philippines from Cardinal Santos Medical Center. What is your arrangement in terms of post-treatment care for patients who came from different countries? Because we've also had our fair experience of patients being sent to different proton centers throughout the world. We've had also experience in patients being sent to India. What is your arrangement in terms of post-treatment care, and when there's an unexpected side effect, what will be your arrangement with the primary care physician? So far, my pediatric patients have been referred to me from a Singapore oncologist, pediatric oncologist, rather than the overseas doctor so far. So usually we of course manage as a team, and the pediatric oncologist will be intimately involved with following up the patient as well as taking care of any unexpected or expected toxicities. Going forward, if for instance you were to refer a case, I think
we would have to be in contact. If they're in Singapore, there's something that I can do about it. But if they're back home, then you would have to be the primary carer for the patient. And then I'll be very happy to be in contact with you.
We've been using.
Yeah.
So we might have difficulty in terms of management as well of the toxicities.
I expect the toxicity to probably be less. So if you're already comfortable managing X-ray radiotherapy toxicities, proton should not be any different, maybe better.
Okay, thank you.
Dr. Lee, to follow up on doctor's question, so that's the post-therapy. How about the workup pre-treatment? What will be the arrangement in case we send patients?
I think if you probably see what you're managing, if you're doing your chemotherapy here and then your surgery here, you probably send for the radiation part to Singapore, and then and then what your workup will be all the usual. So your CTs or MRIs, and then your histology reports. If we need something more, I can always arrange in Singapore. I mean, we have all the usual. You can do your maybe scans for neuroblastoma, PET scans, and so on and so forth. Post-treatment follow-up, I suppose it'd be the same. If the patient is coming to Singapore for follow-up, then I'll order the scan. Or if you're ordering the scan, then I'll be very happy to get an email from you or the patient about the results. Yeah.
So it will be like a multidisciplinary team.
It has to be. Yeah. Pediatric, of course, like any other cancer, of course, but even more so for pediatrics would be a multidisciplinary care. Yeah. I think I'm a relatively small part. You guys are the more important part, actually.
Doctor, I have a question. Is proton beam therapy would it be helpful in younger kids? Like, because we are quite worried in giving the radiotherapy for very young kids, especially those less than 3 years old. No, things can go awry when you give RT to very young kids. But does certain diseases for very young kids?
Yes, I suppose the younger the patient, the more toxicity radiation will cause, and hence the more potential benefit for proton therapy. So the younger, probably the better a case it would be to do proton therapy. Having said that, proton therapy is not magic. It still has the same side effects as regular radiotherapy: second malignancy, neurocognitive, neuroendocrine, and so on and so forth. So if you had to radiate someone in a brain and it's less than 1 year old, you still try to tide over with chemotherapy, by a few more extra months, and then we start the radiation. So yeah, I think it doesn't do away with the current trend of trying to reduce dose and reduce volume. But if you did have to do radiotherapy, then why not choose protons? Yeah. Yeah.
Thank you. Do we have questions? Yes, Dr. Alsa.
Hello. Hi, good morning, doctor. Thank you for your lecture. I'm Dr. Ausa, a pediatric oncologist as well. So I'm just curious, doctor, for patients who will be referred in Singapore, usually, for example, for a medulloblastoma case, how many days duration will be the treatment? Because we have to consider counseling the family, the cost of the duration of their stay there. Will there be also house lodging, board and lodging there? Is it part of the package? That's it. Thank you.
So the duration of stay for the treatment itself would be the same with X-rays as for protons, because the dose is the same. So medulloblastoma, if you're giving, say, 54 gray, it would still be the same 6 weeks or so. Then in addition, we have the planning time, which would take about a week. And then we have to present the case at our local proton tumor board, mandated by Ministry of Health. And we might convene that perhaps once a week. So in addition to the treatment 6 weeks, maybe there might be an additional 2 more weeks to allow for consultation, any scans or reviews, proton tumor board, computer planning, simulation, and so forth. This proton tumor board is a protection for the patient as well as the payers. So that means that we will not be able to be cowboys and treat anything on proton. Other specialists, pediatric oncologists and pediatric surgeons and all that would have reviewed the case and agree that yes, radiation needed. Secondly, protons better than X-rays. And then we can enroll the patient for treatment. And then it's a protection for insurance companies because they're all afraid that if we anyhow use proton now, then we would drive up medical costs unnecessarily. So that has been mandated by Ministry of Health as well. For the stay in Singapore, that one I maybe may have to pass on to Vincent, our authority, who may be able to advise you. I know Parkway has got some kind of discount deal with the surrounding hotels near the hospital so that they get a bit cheaper rate than the usual rate. But I looked at it, it's not that cheap either. It's still about $250, $300 a day in Singapore. So multiplied by 6-7 weeks is still a cost. And then you didn't mention, but another cost would be for young patients, anesthesia. So proton therapy may take longer than X-ray to treat. And so more likely we may need anesthesia for more cases for young children who cannot cooperate to lie still. And that adds on to the cost as well. Yeah.
Dr. Lee, the one that you presented, the $60,000, that is for the whole duration of treatment?
Yes.
And the ancillaries also?
I haven't included anesthesia. That's the anesthetist cost. So this one would include the simulation, the replanning, the daily treatment, the doctor's reviews. Medication is not included, but usually there's not much medication for radiotherapy, unless they need some Kytril for vomiting or something like that.
Because that would be a concern also, the financial part.
Yes. No.
But you've shown that having this treatment would save them in the long run.
In the long run, yeah, that has to be considered.
Thank you. Yes, sir.
Sorry to ask again. If, for example, aside from the CT simulation or the simulation imaging, would the patient need repeat MRI imaging or at your center, or those imaging done here in the Philippines can also be brought there and be used for
planning? It depends on the situation. So if the MRI is a recent one, I'm happy to use that. If I need the MRI from, let's say, pre-chemo or pre-surgery, then there's no way to turn back time anyway. I would use whatever I have that has been done before. If I need a new one, then I'll arrange one in Singapore. As long as you can provide me with the CD-ROM of the MRI or the PET or the CT with the DICOM imaging, I would then be able to fuse that either rigidly or deformably to our planning CT, and I'm happy to use that.
Any more questions from our participants? We have online.
Yes, as you check the insurance company. So if the insurance company covers treatment in Singapore, or maybe proton specifically, since it's new, I'm not sure, then yes, we would be happy to take. A lot of our foreign patients are, or at least some of them are covered by international insurance. so Bupa or Cigna or something. We usually, yeah, AIA, I think they have an international.
Next question, sir. For the treatment itself, so how long does it usually take for the procedure to be done? Because as you mentioned, one of the problem is the challenges in positional certainty, because if we have kids,
Yes,
that's unless they have anesthesia on board,
Yes,
that would
yes.
be quite a challenge.
yes. I think it maybe take an extra 10 minutes or so. Yeah, it's fairly fast. Maybe an extra 10 minutes to just to a bit more careful. We will do daily cone beam CT, unless it's a brain or head and neck case where maybe orthogonal X-ray films will be good enough. Yeah, at least probably once a week may be worthwhile to do a cone beam CT just to check if there's any changes in weight or sinus filling or things that you won't pick up with orthogonal X-rays. So 3D imaging, I think we'll be heavily reliant on 3D imaging. I'm not too worried about the radiation exposure from daily cone beam CT. In my mind, it's more worthwhile to spend a bit of little bit of exposure in the imaging CT in order to get the high dose radiation in the right spot. That's my philosophy. I know people do argue about using daily CTs. We might be in the future, of course, still maybe getting some surface guided radiation to help with the intrafraction monitoring of motion and speed up the initial setup. But I don't think that will totally remove the need for X-ray imaging.
Thank you very much, sir. Any more questions? All right. Thank you again, Dr. Lee. That was very, very interesting, and a lot of us learned a lot.
Thank you very much for
today.
coming. Thank you very much.
So if I may call on Dr. Michelle Rodriguez, our PSPO president, for the awarding of certificates.
May I also call our country head, Mr. Vincent Lai, and our Philippine Office Director, Mr. Edwin Salonga, for the awarding of certificate.
We are awarding the Certificate of Appreciation to Dr. Lee Kuo Ann as the Speaker of the Proton Beam Therapy for Pediatric Medical and Radiation Oncologists, given on the 28th of April of this year and at Marco Hotel. Thank you very much, Dr. Kuo Ann. Another award, a certificate of appreciation, is being proudly presented to Dr. Domelin Arca as moderator of the proton beam therapy for this first CME event for this year at Marco Polo Ortigas. I have to go.
A certificate of appreciation is also proudly presented to Mount Elizabeth as sponsor, Proton Beam Therapy for Pediatric Medical and Radiation Oncologists on April 28, 2023, here at Marco Polo Ortigas Hotel, signed by yours truly and our PSPO President, Dr. Michelle Rodriguez. Thank you very much.
May I call on our country head, Mr. Vincent Lai, for the closing remarks, and then we'll serve our lunch. Thank you, doctors.
Thank you everyone for attending today's seminar. So I didn't prepare any speech, but I have used the previous one that I've done. I would like to just share some good news from Mount Elizabeth Hospital. So actually last year, we also have this new CAR T-cell therapy available in our hospitals. And I'm glad to announce that our first international patients actually benefit from this new therapy is from Philippines. She's a very young lady. And now she's full remission from large B-cell lymphoma already. Yeah, thank you very much. So yeah, I believe all the doctors here share a very common commitment with Mount Elizabeth Hospital, which is to pursue more possibilities and also medical breakthroughs, bring new hope to our patients and their loved ones. So whatever health concerns our patients may have, right? We are here to deliver a world-class level of treatment and the best service to them. So let us continue to work together and bring the best outcome for our patients. Yeah, thank you very much.
May I request for doctors to come in front for a picture taken while we are waiting for our lunch? Is it okay? Group picture. Yes. Can I request everyone to please be in front for a picture taking while we are preparing the lunch with our team? Let's go. Opo, all of us. Yeah. Yeah, everyone po. Thank you. Groupie. Dr. Alba. Dr. Alba. Thank you so much.